Good afternoon, and thank you for joining us today for our update for rural health partners, stakeholders, and communities on the 2019 coronavirus disease response. My name is Diane Hall. I'm a senior scientist in CDC's Director's Office in the Policy and Strategy Office. I also serve as CDC's point of contact and coordinator for our rural work. I'm going to start with some housekeeping. All callers have been placed on mute. If you have a question for the presenter, please enter it into the Q&A box at the bottom of the Zoom screen. We will try to get to it. There's also a chat box, and this is a good place for attendees to share resources with one another, connect with one another, those kinds of things. And as I mentioned, they should be at the bottom of your Zoom screen. If you have questions after the briefing, you can email ruralhealth@cdc.gov. We regularly staff that box and triage emails as they come in. We're not using slides, so they're not going to advance. We are recording the session, and it should be available within a week. As part of our work on this response, we've been in regular communication with federal partners such as CMS, the Federal Office of Rural Health Policy at HRSA, USDA's National Institute of Food and Agriculture, and the VA Office of Rural Health, as well as non-governmental partners such as the National Organization for State Offices of Rural Health, the National Rural Health Association, and Rural Health Information Hub. Thank you to our partners for helping us curate the questions we'll be using today. We've had tremendous interest in this briefing, and we have received many questions ahead of time. Please note that if the question is not within CDC's purview, we are sharing those questions with the relevant agencies. I'd like to thank Scott Miller and my CDC colleagues working on the coronavirus response for helping to put this briefing together, and thank you to our partners who helped disseminate the invitation. My office has been working with different teams working on the response, and we would like to hear about any good and promising practices being used in your state to ensure that all patients in your state are getting the care that they need, whether it's related to coronavirus or not. We're interested in highlighting and sharing those. So if you have an idea for that, you may send those to ruralhealth@cdc.gov with the subject line Promising Practices. We're thrilled to have Deputy Secretary Eric Hargan from HHS here with us today, and now we'll turn it over to Mr. Hargan.
Thank you, Dr. Hall. Hello, everyone, and thank you very much for joining me on this call today and all of us here at HHS. I'm glad to connect with so many of you who care about rural America, who've played a role in the COVID-19 response so far, and who are working to ensure that we're supporting the response we need to the pandemic in rural areas. I have a special kinship with many of you. I was raised on a farm outside a town of 800 in southern Illinois. The rural healthcare heritage in my family runs 5 generations deep, back to Doc Hargan and his horse and buggy, and believe it or not, rowboat, visiting patients in the late 1800s in Pulaski County, Illinois, the same county where I was raised, leading up to my late mother, who worked in a rural hospital for 58 years. Many of my relatives work as healthcare providers to this day in rural areas. So I have some sense of the challenges faced in rural healthcare in normal times, let alone a pandemic, in terms of both challenges in access to care and in underlying health challenges faced in rural communities. At the same time, having grown up in farm country, I also know that one trademark of rural America is resilience, and I believe we've seen that strength shine through already. As the President and Vice President have repeatedly said, it's going to take a whole of government, all of America approach to defeat this virus. And that means close cooperation among every level of American government and society. I know that many of you have been working around the clock on this crisis, and I know that all of you, both in your public capacity and in the lives you lead in your communities, are eager to return to business as usual. And believe me, we want that too. But we have a ways to go. As all of you know, we remain under the national social distancing guidelines that the President and his task force have extended to April 30th at the recommendation of our top public health leaders here at HHS. We greatly appreciate the work of many state and local governments to issue more detailed guidelines or formal restrictions on business and on social activities, And these leaders have the ability to modulate these responses so that they make sense for more rural or remote communities. As many of you know, the CDC has put out specific recommendations for how Americans living in rural areas can prepare and keep themselves and their communities safe. The President recognizes how the virus has been a burden on rural governments and communities already, so I want to take a moment to describe the range of ways that HHS is supplementing the work we do with you in normal times with new support from the CARES Act. Across HHS, every division that has received new resources, and thanks to Congress for their generosity in providing these new resources, we are working around the clock to get it to where it's needed most, and that certainly includes the 60 million Americans who live in rural areas. Just yesterday, we announced new steps on the $100 billion in the CARES Act to support healthcare providers directly, recognizing that so many of them are under strain for various reasons. This week, we will begin the initial distribution of these payments to hospitals and to healthcare providers across the nation, distributed based on how much relative revenue they receive from Medicare. This approach will prioritize our rural hospitals and providers that receive higher Medicare reimbursement, dialysis facilities, as well as hospitals in hotspots like New York, and further tranches of this money will also have a focus on places with special needs like rural areas. We've endeavored to make this process extremely simple, and we expect 500,000 or so providers will see funding show up in their bank accounts this week. Now, as a condition of receiving this money, providers will not be allowed to balance bill uninsured Americans for COVID-19 testing and treatment, and they will be reimbursed for that care at Medicare rates. Further details about these distributions will be forthcoming soon, and further tranches of this money will concentrate on those who did not receive payments as much as possible from the initial formula that we used based on Medicare. So we will be working quickly to develop further formulas to distribute the remainder of the money to areas that may have been disadvantaged by the fact that they were not in the Medicare system as strongly as others. These payments are far from the only way we're working to support rural healthcare providers. We've also opened up new flexibilities for providers to waive copays and to use everyday technology like FaceTime or like Skype to connect with their patients. Greater use of telehealth allows providers to keep offering services to their patients even in challenging times, while also helping patients in hard-to-reach areas get the care they need. I've already heard very strongly from many different kinds of providers, including community health centers and others who are using telehealth already, and the flexibilities that we've given them to reach patients when they're not able to come into the sites because of concerns about infectious disease. Now, for those of you who interact with tribal health care, the Indian Health Service will very shortly be rolling out its program for using these flexibilities. Today, we also awarded more than $1.3 billion to 1,387 community health centers across America, many of which are frontline primary care providers in rural communities. Now, I want to briefly summarize some of the important new resources for other work HHS does with you, which will be essential to ensuring that services are provided and needs are met, especially in rural communities. First, CDC is working to push out $1.5 billion in the CARES Act's state and local preparedness grants, which combined with the first supplemental bill amount to about $2.5 billion provided for state, tribal, territorial, and local public health needs. There's a set-aside in CDC's grant program for tribal health needs, and the CARES Act also provides more than $1 billion for critical response needs in Indian country, including supplies, staffing, and increased telehealth capacity. We also know that mental health is going to be a challenge, and that burden is often felt acutely in rural areas. My late father was chairman of rural mental health in our community, and so I grew up in and around these issues. The CARES Act provides $250 million for certified community behavioral health clinics, $50 million in new money for suicide prevention, and $100 million in flexible emergency funding for states and tribes to use to address mental health needs. SAMHSA has now posted the funding opportunity announcement for that flexible emergency funding and I encourage you all to take a close look at that posting. We also recognize that human services providers, whether they serve vulnerable youth, families, or older Americans, are under strain, and that their work can be especially challenging in rural areas. HHS's Administration for Children and Families is receiving $6.3 billion in new funds, which it is working to get out the door expeditiously, with a focus on supporting Head Start providers and augmenting LIHEAP, Child Care and Development Block Grant, and Community Services Block Grant funds. The Administration for Community Living also received $955 million to support aging and disability services programs like getting meals to our seniors, an activity we have already dispersed some new money from the earlier economic relief legislation. These funds are aimed to support your work and your communities, and we will work to ensure that rural communities remain front of mind as our response and the pandemic continue to evolve. As the President has emphasized, we are facing a tremendous battle now, but with your help and your continued leadership, we are going to emerge victorious. So thank you all again for giving me the chance to speak with you all today, and thank you so much for all your hard work. I'm now going to hand things back to Dr. Hall.
Thank you so much for that update and for joining us today, Deputy Secretary Hargan. We know how busy you are, and we appreciated the information and your ongoing commitment to improving the lives of Americans living in rural areas. Thank you. And now I will be turning things over to Dr. Jay Butler. Dr. Butler is CDC's Deputy Director for Infectious Diseases. He will provide a status update, and then we will move to Q&A. Dr. Butler?
Great. Well, thank you, and good afternoon, everyone. Good morning to any of you in Hawaii. So I want to start with a situation update, provide a little insight into some of the recent breaking issues, and then I look forward to taking your questions. The pandemic, since we last spoke, which was in late March, has continued to accelerate and spread around the world. Here in the United States, roughly 400,000 cases have been confirmed, and sadly, roughly 13,000 people have lost their lives to COVID-19. And I know that anytime something this big happens, that it touches very close to many of us. So we extend our sympathies to those who have lost loved ones or co-workers. Saw a little of that this weekend. I was working at the FEMA National Response Coordination Center, and one of the veteran FEMA responders who was in a lead role after 9/11 and after Hurricane Katrina, we learned actually had died of COVID-19 late last week. And so we do anticipate that, unfortunately, we'll continue to see more instances of people who we've worked with and those possibly who are near and dear to us becoming sick and possibly even dying of COVID-19. Just as what's happening around the world, the rates of transmission are somewhat variable across the United States. New York City has been one of the hot spots, certainly for the past 10 days, but also seeing other areas of significant increase, including New York State, New Jersey, Louisiana, particularly around New Orleans, Michigan, around Detroit, and Illinois around Chicago. The trend is towards emanation out from these areas into peri-urban and suburban areas, and also we see cases in rural areas as well. So I think it's very important to realize that COVID-19 is not just an urban problem, but something that is a risk for all of us throughout the United States. Some of the response to rural areas at the CDC has focused on some of the areas that have not had high rates of transmission yet. So we've been mobilizing community protection teams to be able to go out and support the state and local officials in areas where there has been minimal transmission so far, to be able to assist with controlling the rate of rise in the number of cases with the overall goal of flattening the curve. Flattening the curve, I know that many of you have been involved in pandemic planning for a number of years. That's quite familiar, but Flattening the curve is now a household word, and of course what we're talking about is not only reducing the number of cases, but spreading the impact of the pandemic over as long a period as possible so that critical infrastructure and the healthcare system doesn't get overwhelmed by a large number of people who become ill all at the same time. We currently have community protection teams that have either been deployed or are about to deploy to locations in Kentucky, Ohio, West Virginia, New Mexico, Wyoming, Idaho, and Alaska. Currently, the rates of rise in some of the areas most heavily impacted, there is some glimmer that the community mitigation efforts are beginning to make a difference, and the increase in the number of cases is beginning to slack off a bit. I want to emphasize, though, that's not a decline in the number of cases, but a decline in the increase in the number of new cases. So we still have a long way to go with this. So 96% of us live in areas where there's a stay-at-home order. And this is part of the whole context of social distancing, to be able to be separated from one another by at least a distance of 6 feet. The data to date suggests that the transmission of COVID-19 is primarily through respiratory droplets, meaning that the virus is present in the nose and the mouth and can be spread in droplets that are generated during coughing, sneezing, or even speaking. Some evidence of transmission from contaminated surfaces, which is why we stress also hand hygiene, washing hands well for 20 seconds with soap and water, or use of alcohol-based hand gel. And I do recognize that that can be a challenge in some of the rural areas where there's limited availability of piped water. So the alcohol-based hand gels is an option there. Also, the evidence of airborne spread is fairly limited at this time, although we've been able to create that type of instance in laboratory conditions. I think we're not seeing that epidemiological evidence of that at this time. So think of this somewhat as we think of how influenza spreads, that the most important thing is to be able to separate from one another for a distance of at least 6 feet. And I'll return to other steps that can be taken in a minute. But I wanted to highlight the importance of social distancing. A MMWR report was put out by CDC just a couple of hours ago describing cases that occurred around two family gatherings, a funeral and a birthday party, which altogether resulted in 16 cases and 3 deaths. And I know while these are very disruptive events, this is a very disruptive event that has made life very different. Things like funerals and birthday parties, there's a reason to defer those type of events because that type of gathering can lead to transmission of cases. And then I wanted to provide an update on 3 new aspects of COVID-19 and its causative virus, the SARS-CoV-2 virus, that is just come out over the past couple of weeks. It's important to remember that COVID-19, as well as its causative agent, the SARS-CoV-2, weren't even known to exist 4 months ago. So it's humbling to realize how vulnerable we can be to an emerging infectious disease, and also how challenging it can be to learn things as quickly as we need to. Although it certainly is a very different world in the 21st century than, say, in the 1918 influenza pandemic, when very little was known about what was causing the number of illnesses and deaths that were occurring. So the first thing that we've learned much more about is the role of transmission prior to onset of symptoms or in people who are completely asymptomatic. This has been a concern really from very early on in the pandemic, but as we've as we've collected additional data and had more experience with this virus, there's a couple of lines of evidence that suggest that it's different from SARS. In SARS, caused by a very closely related virus, the peak level of infectivity seems to be around the peak of symptoms. For COVID-19, however, the highest level of virus in the nose and the throat is at time of symptom onset. And we now have an increasing body of evidence that the amount of virus in the nose and the throat prior to onset of symptoms can be quite high. And some people who become infected and never develop any symptoms at all also have high levels of virus and are capable of transmitting the virus to others. So as part of the response to this new information, CDC expanded some of its recommendations on source control to include cloth face covers. This is building on a body of evidence and some recommendations that we may have discussed on March 26th, where we talked about when people who are symptomatic should have some type of mask to be able to reduce the spread of respiratory droplets to others. The recognition that transmission could occur from people who are not yet symptomatic or never developing symptoms is what led to the recommendation to begin using face covers whenever out in public and at risk of exposing others. A couple of things are critical to understand about this. First of all, face cover protects the wearer, does not protect the wearer, but protects those around them. Let me stress that again to make sure I've got it straight. Wearing the face mask is to protect those around you. I've actually have a face mask that I've been wearing. I've had to go to the drugstore and to the grocery store. I've noticed in both locations more than half of people are wearing them. Also, most employees are wearing them. And actually, I've had two instances where an employee had commented thanking me for wearing the mask because they do understand that I'm doing it to protect them and they're wearing their mask to protect me. We do focus on cloth face coverings rather than on surgical masks or on personal protective equipment such as N95 masks. While these type of medical devices do also provide source control, the supplies are fairly limited, so we really do encourage people to be able to fashion cloth face coverings unless there's no other choice. I specifically would like to call out that it's really not appropriate to be wearing N95s in the community because the role of masks for protecting people in the community is very limited in terms of how it protects the wearer. And also, we want to make sure that N95s are available for our healthcare providers who are putting their lives on the line, taking care of people with severe COVID-19 and who may be involved in aerosol-producing procedures. The other aspect I wanted to point out about the face covers is it's part of the overall community mitigation effort. It does not replace social distancing or the other things that we're doing to be able to slow the spread of the COVID-19 virus. It also doesn't replace hand hygiene or cleaning frequently touched surfaces such as doorknobs or touchpads. The second update I wanted to provide, I think on the last call we talked about whether or not there's any risk of infection from animals. So far there continues to be no evidence of transmission happening from animals to humans. However, in the past week there has been an instance of transmission from humans to animals. With the Bronx Zoo identifying now a number of tigers and lions who've had illness, respiratory illness, and who had COVID-19 confirmed by a swab. And let me reassure you, my veterinary colleagues have described to me that the animals are put under general anesthesia before a swab is collected. That would be otherwise a pretty interesting procedure. And this fits with some earlier laboratory data from China where a number of types of animals were inoculated. The only species that was successfully infected but at low viral counts was house cats, and we really don't know if house cats could potentially infect humans, but it does raise the question of whether or not they could be infected by humans. However, they were not successful in creating infection when inoculating dogs, pigs, chickens, or ducks. Right now, our recommendation for people taking care of animals is, particularly if they're symptomatic, to avoid contact. Ideally, again, think in terms of minimizing exposure to any kind of respiratory secretions. The third area where we continue to learn more is who's at risk for more severe illness and for death. On Monday, CDC put out an MMWR report looking at the rates of infection among children, documenting what had been observed in China earlier, that children appear to be at lower risk of severe illness or death, although the risk is not zero. There were at least 3 instances where children have died of COVID-19 in the United States, but the risk is clearly much lower among kids. Unfortunately, we're also seeing that health inequities are enhanced during a pandemic. We're seeing evidence of higher rates of hospitalization among Black people, and we're also seeing outbreaks in situations such as shelters for the we don't have a lot of data yet in terms of American Indian and Alaska Native people, but I think it's important to recognize that chronic underlying conditions, which are more common among people of color, such as chronic heart, lung, or kidney disease or diabetes mellitus, have been associated with higher risk of more severe illness with COVID-19. So to close, I think everybody knows this is something that the world will never be the same again, to pull a line from the opening song of Hamilton, and we'll be doing things different for some time to come. Just when we begin to scale back on the community mitigation will depend on how the pandemic continues to evolve. We are working very hard at looking at the various interventions and how that's slowing spread, and you'll be hearing much more about that over the next couple of weeks. And then finally, I just want to thank you for joining us today. As Deputy Secretary Hargan said, this is a whole of America response that's required, and it really takes all of us to be able to address this really remarkable situation that the world really hasn't seen the likes of since the 1918 influenza pandemic. So with that, I will stop and I will turn it back, and I'll be happy to take questions.
Thank you, Dr. Butler. We appreciate that update. So I'm going through some of the questions. If folks on the line, if you're on Zoom, could you type your questions into the Q&A box versus the chat box? It's easier for us to monitor which questions we answer, and we'll have a record of those. So please put them in the Q&A box, not the chat box. So we do have some questions about masks and face coverings. What is important to keep in mind when people are making cloth face coverings? The type of material, what parts of their face need to be covered, etc.
Great. So a couple of things. First of all, this is a situation where filtering capacity is probably not important. Think more in terms of splatter shield. What you're trying to do is prevent those droplets that come out of the mouth during speaking, singing, coughing, or sneezing from spreading to others. So basically, a cloth that is breathable would be the goal. I have a cotton mask myself. You can make a fashion statement if you wish. I have fabric that has bears and fish on it, since I call Alaska home. And we have a variety around the office here where we wear them in the EOC at CDC now. The type of material, I've seen some made from materials such as sports bras, very breathable fabric. I think it's very important to recognize, though, that people with compromised lung function or children younger than 2 years old should not be masked. I've seen both some remarkably innovative ideas and some remarkably bad ideas so far. I saw someone was selling a mask with a pacifier built on the inside, which, given that infants are obligate nose breathers, having a mask on is probably not a good idea. On the other hand, I saw a mask that was created so that it had a clear plastic shield over the mouth, so that people who are caring for those who are deaf would still be able to speak, and their lips could be read. The CDC website has some instructions on how to make a mask. If you just Google how to make a mask, you will find quite a number of options out there for all the DIYers and crafters out there. This is a great opportunity to help your family and help your neighbors by making masks and sharing them. Because we really do believe this is an additional step that can be taken as we've learned more about COVID-19 to be able to protect our communities.
Great. Thank you, Dr. Butler. I'd like to add that the CDC instructions on making cloth face coverings includes directions for folks who choose to sew them and folks that choose not to sew them. And it is focused on using items that you would have in your house so that you wouldn't need to go out to a fabric store. Dr. Butler, we have a couple of concerns about this guidance about cloth face coverings. One is concern about people thinking that this makes them safe and they don't need to do social distancing, and what kind of messaging is CDC providing around that. And the second is related to culturally competent messaging. For some groups, for example, African American males, they're often considered threatening when they wear face coverings. Is CDC planning any messaging around that?
Yes, and thank you for that question. In fact, I joked when I had to go to the drugstore last night. I walked in and commented that I wouldn't normally walk into a store with a mask on because I'd be afraid the store owner might shoot me. But it's become it seems like it's the look now to have. Regarding the question of cultural competence, that's an area where we really welcome input to make sure that we're delivering messages that are effective. And we've also done a little bit of survey data to look at the level of uptake. One of the areas that sort of stood out to me was that the lower socioeconomic status tended to increase the likelihood of wearing a mask, which I think is probably a reflection of these are people who are most likely to be employed in the service industry and be interfacing with the public, providing critical services such as keeping the grocery stores open and the drugstores open. But that said, we want to make sure that we're delivering messages that are understood both culturally and in terms of language. We have a number of languages either out there or in development, especially Spanish as well. So being able to address those concerns and the shortcomings in the messaging is something where we would love to hear from you so that we can make sure the messages are effective and reaching the people that they need to reach in a way that is going to work.
Great, thank you. We are getting some questions from folks in rural communities asking about the ability to donate equipment, particularly if they've got masks and gloves, but the box has been opened. Can those still be donated to healthcare facilities?
Yeah, it's a great question, and actually, you know, the whole response, the whole of government response, is now being primarily led by the Federal Emergency Management Association, or FEMA, in cooperation, sort of a tripartite lead of FEMA, the Assistant Secretary for Preparedness and Response, and the CDC. The FEMA website actually has some information on supplies, and also it's probably important to check with your state or local health department in terms of what are the possibilities for donations. Things like masks that may be expired and may not meet the standards for use in a healthcare facility, however, still would have the utility as that source control. So that also would be an option for a face covering.
Great, thank you. So I'm seeing some questions in the Q&A about using N95 masks. Should those be worn in all surgeries at this time, given the fact that we aren't able to do really widespread testing and some patients may not be showing symptoms but may be carriers?
Yeah, so the N95 use, the question was specifically for surgeries, but I would take it a little more broadly in terms of any healthcare environment where there's a possibility of aerosol-producing procedure, particularly related to respiratory secretions. So whether or not the N95 is the best way to go during surgery really depends on the type of procedure that's being done. I would also particularly want to call out any emergency dental procedures might be not often recognized as an aerosol-producing procedure, but certainly is. While most routine dental visits have been delayed during this time of the most drastic social distancing and community mitigation, still there will be dental emergencies that require care, and the use of things like high-speed drills certainly can produce an aerosol. So that would be a situation where an N95 respirator would be very appropriate.
Great, thank you. We're seeing a lot of questions about rural areas being concerned about being able to secure rapid testing devices. Does CDC have any suggestions?
Yeah, and this is where speaking with your state response coordinators, the folks that are doing the supply chain management now through FEMA can hopefully be helpful. There's a large number of the machines, the Abbott machines that provide testing of moderate complexity that have gone out into the states. I think there are still some challenges getting enough of the reagent cartridges out there, but at least it's moving us closer to being able to push the diagnostic capacity out to where the providers and the patients are. I think in the coming weeks, what I'm certainly hoping that we see is antigen detection type tests in ways that we might be able to do true point-of-care diagnostics, such as what may be done with something like a rapid flu test.
I have a question that's related to that just came in, specifically asking about the efficacy of the new serology testing to look for antibodies, in a rapid POC test.
Yeah, so great question. Thank you for that. Well, first of all, it's important to recognize that for diagnosing acute infection, antibody tests are probably not going to be useful. The data that are available show that the antibody response begins to occur early in the second week of illness. One of the things also that I think is important to know is that we are working hard to determine is whether or not these antibodies are neutralizing antibodies, that is, antibodies that likely reflect immunity to reinfection. So there's a lot of work going on right now, both to evaluate the quality of the tests, and there really are a large number that are going through the emergency use authorization approval by the FDA, and then also determining whether or not they really reflect immunity or just exposure to the virus. I know some providers even who have had COVID-19 because of the uncertainty of the risk of reinfection are continuing to use PPE, which seems like a prudent measure at this point in time. This is an area where I think we will know much more very soon, and so we look forward to sharing additional information as it becomes available.
Great, thank you. I'm seeing some more questions about masks. One in particular is that in a lot of rural areas, there has been some inconsistent messaging, and in some communities where we're not seeing a great deal of community spread, people are being encouraged not to use face coverings. What are your thoughts on that?
Yeah, it's a little disheartening that anyone would discourage using face coverings because it's not something that necessarily has major downsides, but I would stress it's something you do for the people that you're around when you're in public areas. The importance of using face coverings is probably greatest in areas where you have higher levels of transmission. But, you know, given some of the things that we've already talked about today, such as whether or not testing is available in some of the more remote areas, whether or not there's a significant amount of transmission that may be from asymptomatic people or people who've not yet developed symptoms or have very mild illness, I think it's an important consideration really wherever you're at.
Great, thank you. I'm also seeing some questions, and we received this question ahead of time, that there seems to be a lot of contradictory and conflicting information about how long we need to be practicing social distancing, and that jurisdictions, some have provided guidance, some have not. Can CDC provide any clarity on that?
Yeah, and it's not surprising that it seems confusing because this is an evolving pandemic, and as we learn more, the recommendations can and should change as we know what the science is telling us about what we can do to slow the spread of the infection. So I think it's most important as we look at the possibility of scaling back community mitigation that we're driven by data and not by a date that's selected at some point in the future. And also recognizing that the scale up or the scale back is going to be variable in different locations. Some areas may really start to be on the downward trend, while other areas may be on the upward trend. This is an area of very intense work right now to determine what are going to be the best metrics to determine when to scale back and when is the best time to do that. For example, school closures, I know that there are, all 50 states now have statewide school closures. There's quite a bit of variability in terms of the target dates for reopening. I think 15 states now have actually canceled classes for the rest of the school year. That's not because people, I think, are necessarily confused so much as there are issues surrounding not yet knowing quite what's going to be the best way to intervene and at what time. So this is an area where I think our recommendations will continue to evolve, and I would not expect to see necessarily nationwide guidance, but there'll be sort of general guidelines, but the actual application in different states and localities will depend on the status of the pandemic in that area.
Great, thank you. I'm seeing some additional questions about other types of protective, well, not equipment, but questions about gloves. So should people be wearing gloves in public settings? Could they use reusable gloves, I guess the kind that you use to wash dishes? Would there be any benefit there?
Yeah, I don't know of any additional benefit to what could be achieved with good hand hygiene. I mean, it's, I think, really a personal decision whether you do that. I would caution, however, that gloves can become contaminated as well. So Whenever the gloves are removed, it's important to still practice good hand hygiene, and also, just as the case with the hands, to be careful about gloves going to the face, and being aware that it's not a barrier that will necessarily provide any known level of protection.
Great, thank you. There's also a question about CDC's recommendations on sanitizing masks and PPE. Should they use Lysol, an alcohol sanitizer, do UV lights work, etc.?
Yeah, so there's, I think, a couple of different questions in there. Regarding sanitation of PPE, because of the short supply of PPE, there's been quite a bit of interest on different measures that can be taken to allow reuse of PPE. In particular, there's one fairly large-scale tool that has gone out to at least 5 locations and will be going out to others in the near future, which uses a superheated hydrogen peroxide mixture, which actually allows for decontamination of used disposable N95 masks, and under ideal conditions will facilitate reuse of those masks up to 20 times. That process takes basically about a day, so it's a way for hospitals to be able to recycle some of the use of their PPE, with only about 10% not being able to be reused, primarily because they've been soiled either by getting splashed or by the wearer having makeup that got on the PPE. Regarding the face covers, the recommendations for those is basically they can be laundered as well as any other clothes that are worn, and we recommend ideally that be done daily, just recognizing that there's a lot of things that are in our noses and mouths, and so it's good to keep those articles of clothing as clean as possible.
Great, thank you.
Oh, you also
Yep.
asked about surfaces. So the recommendations there are that household disinfectants can be used, and these will be things like weak solutions of bleach. Hydrogen peroxide can be used as well, or alcohol-based cleaners. It's particularly important to wipe down surfaces that are frequently touched, such as touch screens or doorknobs or door handles.
Great, thank you. I want to shift. We are getting a lot of questions in the Q&A box, and I just want to remind everyone that Zoom will keep a record of those. So if we're not able to get to it today, we will still have your question. And we will work to triage those to the relevant agencies if it's not a CDC question, and we will work to see about getting answers where we can. There's a lot of questions about data and models that are out there, and we've heard from our rural partners that rural-specific data from CDC would be really helpful. There is still that perception that this is an urban problem, and this is influencing decisions about prioritizing things like supplies, ventilators, tests, things like that. So is CDC planning on releasing any rural-specific data?
Yeah, thank you for that question, because it's very important that we let the response be guided by the available data. So the work that's being done with the data at the National Response Coordination Center really is looking at the rates of disease and the changes in the rates of disease, as well as the rates of death and changes in the rates of death in the over 3,100 counties around the country. So every effort is being made to make to look at the data as much in a granular fashion as possible, so that appropriate movement of much needed goods such as ventilators, such as PPE can be done, so that ideally it's not just being sent to places that have been impacted, but those that the modeling suggests will be impacted next. Regarding any reports from CDC specifically on rural-related disease, that is something that certainly could be coming down the pike in the future, but I don't have a specific date of any reports coming out specifically focused on rural situations.
Thank you. As people are thinking about the multiple models that are out there, should rural communities be assuming that there will be some sort of lag before it gets to rural? We are seeing there are cases in rural areas. Are there any rural models that you're aware of, or how should rural be modeled?
You know, it's really quite variable, and of course, models depend on what goes into them, and that's why you hear estimates of things like numbers of deaths that can vary by several-fold. It is challenging in more rural areas because the numbers also become much smaller to work with for population, so the variability is even greater. But I think it's important to recognize that there are counties that may not necessarily be recognized as urban, such as the county around Albany, Georgia, where the rates of disease already have been quite high, driven in part by some gatherings as well as transmission that occurred in a healthcare environment. So it's really important to know what's going on locally, work with your local or state health department, as well as emergency management to do what you can to be prepared for when the rates of disease increase.
Great, thank you. There's a question about low number of positive cases in rural areas. Do we think that's because we're not seeing transmission or because we're not testing at the same level in rural communities?
I think it's a combination of both, although I think it's going to become more a matter of, I think the view is going to become more clear as the availability of testing gets pushed out more to the rural areas. Also, there's increased testing capacity in the IHS and tribal hospitals. So I do think if we see areas that are not seeing a lot of disease yet, that's going to be very helpful. I do want to emphasize, though, that there are other important measures than just laboratory test results that are important. For example, we now have the term CLI, COVID-like illness, riffing off of influenza-like illness, as a measure that is available and has data coming not just from urban areas but around the country. On the CDC website, we now have a weekly COVID view. If you're familiar with flu view and like that format, you'll like this because it's exactly the same. And in fact, if you look at the ILI rates, you see that there has been a shift over the past 3 weeks with the number of illnesses that are associated with documented influenza on the downturn at the same time as the number of respiratory illnesses caused by COVID-19 on the upturn. So that will be one way, I think, to get a look at what's happening nationally, and of course the maps that are a part of that should be useful as well.
Great, thank you. It seems that a lot of attention is really being paid to urban areas because of the number of cases and deaths in those areas. Do you think there's a risk for rural communities when urban areas are no longer under stay-at-home orders and people may be traveling to rural areas?
Yeah, that's a great question. And first of all, one of the concerns that we have in rural areas is just demographically, the population is generally older in rural areas than in urban areas, and older people are at higher risk of more severe infection and at higher risk of death. The spread of infection by travelers is very real, and that's why most states have some type of stay-at-home order to be able to reduce the spread of the virus from one community to another, recognizing that some communities are, as of yet, less impacted than others. So I think it's important not to blame our city cousins for spread of the epidemic, but it's also a good time for our city cousins to stay put and not come to visit, so that the entry of the virus into rural areas can be slowed as much as possible.
Great, thank you. Some recent news stories have indicated that the virus is disproportionately affecting African Americans, and there seem to be some gender differences. Is CDC or the federal government collecting data by race and gender, or are they investigating this disparity?
Yes, and that gets back to my opening comments about some of what we're seeing about higher than anticipated hospitalization rates among African American people. And it's really important to pay attention to that. I know back maybe even a month ago, there was internet rumor that black people are inherently immune to COVID-19. And I have no idea where that came from. If anything, it might have come from looking at some of the world maps that WHO had that showed very little involvement in African countries, which was most likely a reflection of very limited testing capacity. I can say that as testing capacity has increased in Africa, we're seeing COVID-19 in almost all areas. I think you're absolutely correct in saying that we're continuing to study that more in depth, but we have the data now that suggests that that is indeed a real phenomenon.
Great, thank you. Does CDC think that rural community members could be helpful in their communities, assisting perhaps rural hospitals and clinics in some way, perhaps doing some contact tracing, or following up with people who've been exposed?
Yeah, that's a great question, because while we're socially distanced, it's important to not be socially isolated and help our neighbors and to help our communities. The best way to explore how to do that, I think, is to check with your local community, either emergency response or health department. Also, if you're part of a faith community, see if there's work being done. I know we're encouraging now that gatherings such as worship services be canceled and those type of events be delivered virtually. But at the same time, I grew up with the expression, the church is more than a building, and maybe that's never been more true, that as bodies of people bound together by faith, whether in our church, our synagogue, or our mosque, this is the opportunity to come together and to help our communities. So if we have faith leaders on the line, I would encourage you to think about how people in your community, particularly older people, are getting food, medicines, and other services. There are some new guidelines on the CDC website about running errands that specifically address concerns around food delivery and delivery of essential goods to people who may be homebound, and how to make sure that those type of interactions do not increase the risk of transmission of COVID-19.
Great. CDC is adding new guidance and new resources to our coronavirus website daily, if not more frequently. So I would encourage folks to sign up for email updates so that you get those. In addition to the guidance for faith-based communities, there is guidance for EMS and law enforcement. So we're close to time. Dr. Butler, I don't know what your schedule is looking like. We have a lot of questions still coming in.
How about we take two more, and then remaining questions, perhaps we can follow up with one way or another.
Okay, that sounds good. It's a lot of pressure. Let's see.
Yeah, you have to pick two good ones, Mel.
I know. There's so, I've like 5 pages Word document. There is one question about farm workers. You know, we talked a little bit about animal transmission, human to animal, animal to human. We talked a bit about farm workers the last call we did, but there's some concern that there are farm workers, either migrant farm workers or folks working in large industrial dairies, working in the meatpacking industry or poultry processing, and a lot of them often live in very close quarters and work in very close quarters. So what would CDC recommend about trying to mitigate spread in this population?
Great. So first of all, it's important to recognize that farm workers are essential personnel, that these people, when they do their job, they're keeping us all fed, they're keeping the supply chains for nutrition open. So it's critical that people continue to be able to work. In fact, I'm told that Department of State is continuing to grant visas to migrant farm workers out of recognition of the fact that our agricultural industry is part of the vital infrastructure that's needed to be able to maintain society. It is challenging because oftentimes, particularly migrant workers, are living in fairly crowded situations, working in fairly crowded situations as well. But ideally, the recommendations would be able to encourage and support social distancing, good hand hygiene, and use of face coverings, again, oftentimes are used in food, such as thinking in terms of meat packing plants. The type of mask that may be required for that type of work would also serve the dual function of source control. The other thing I'll just comment about food, and I know this is a little off topic, but it was interesting to look at some of the data that we've seen about Yelp reporting and inquiries. Some types of industry are actually on the up slope, while other parts are very much on the down slope. But one of the areas that has gone up is community-supported agriculture. So many people, I think, are putting in gardens during their time when they're socially distanced. Anyway, I think so I would just conclude that by saying that some of the guidelines that apply for everyone who has to continue to work would also apply to farm workers and people working in food processing plants.
Great, thank you. What suggestions do you have for rural communities who have a large population of folks that are at risk, either homeless or a significant population of the elderly folks?
Well, the most important thing is, again, social distance as much as possible. I know that's particularly challenging for people experiencing homelessness. And we are seeing outbreaks of infection among people experiencing homelessness. We have specific guidelines available on the CDC website addressing a number of the issues surrounding homelessness, both in terms of how to prevent infection and also how to manage persons experiencing homelessness who may have illness but not of sufficient severity to be hospitalized. In terms of older persons, it actually brings up some of the issues around when do we begin to scale back some of the community mitigation efforts. And I think one of the areas that it's important to think about as we look down the calendar at the coming weeks and months, that I don't anticipate that people who are at high risk are going to stop being at high risk. So as we perhaps become more mobile again, I think it's going to continue to be critically important that people who are older have the ability to be able to stay at home and to limit their contact with others. I know that's particularly challenging in family situations where everyone wants to see adult children and grandchildren, but at this time it appears to be the best measure to be able to protect our elders. just because we're socially distanced doesn't mean we have to be socially isolated. So a phone call or even a video chat, if you have that kind of capacity, is a way to maintain those relationships and stay in touch.
Thank you so much, Dr. Butler. We appreciate your taking time to answer these questions, and thanks to all of you for joining us. If you have additional questions that you did not submit in the Q&A, please email those to ruralhealth@cdc.gov. That is also the email address to use if you have promising practices you'd like to share. We are recording this session, and it will be available in 2 locations. The URL was posted in the chat. Thank you, everyone. Thank you for the work that you do, and stay safe.
All right. Thank you, everyone.